You obviously pour your life into a lot of kids, and so I'm not a doctor. I have a PhD. It's in history and health policy analysis, so the only thing I can cure is insomnia, and it's largely by the stuff that I've written I just give to people. But I just want to say thanks, because I have 3 kids who get into all sorts of trouble and do all sorts of things, and we have a variety of diseases in our family, and my wife is a doctor, so we panic sometimes over incidental stuff, and so we've had a number of pediatricians who've climbed us down off the ledge and made sure we're okay, and also given us really wise advice. And so you probably don't hear enough times the thank you from parents who appreciate when we're irrational, but so I just wanted to say thank you on behalf of the people who don't say thank you, including myself. So it's a real privilege to talk to you, and I've got about an hour, so the lecture is basically going to help you solve all your ethical problems, and then you'll be able to go home. I teach, I'm a faculty member at UT Southwestern, and I do clinical research, really health systems research, taking a look at how health systems provide care to poor and vulnerable populations, and then we try and develop interventions to do a better job of that. But I'm a little bit of an odd bird because I have a degree in history and health policy analysis, so on the side I do a lot of teaching and talking about ethics. I teach the medical students how to think ethically. And I don't know whether or not I do a good job with that, but that's what I do. I sit on the Children's Hospital in Dallas, the Ethics Committee, and also for the Institutional Review Board. And then I teach at the School of Management, Business Ethics and Healthcare Business Ethics at UT Dallas. And so I spend a lot of time thinking about medical ethics. And I want to talk with you about that today. But before I do that, what I want you to do really quickly is turn to the person next to you, and when you hear the phrase medical ethics, what is the first thing that comes to your mind? When you think of the phrase medical ethics, what's the first thing? Just turn to your neighbor right now and tell them, and the answer cannot be, I got to get this CME out of the way. Well, it can be, but if that's your first answer, then come up with the second one, all right? Okay, anybody, what were some of the things, when someone says medical ethics, what are the things you think about? Anybody brave enough to volunteer, or I'll start picking? Lawyers, okay. Right, because medical ethics is really about law and who's going to sue your pants off, right? Okay, somebody else said something. Helping patients, okay, very good, and we'll come back to that. Other ideas? Life and death, right. Usually that's what we're thinking of. Any other ones, ethics? Informed consent. Very good. And what does that mean? Is that signing something, or is that taking an hour to explain everything that you're about to do or somebody else is about to do? So, okay, so now I want you to turn back to your neighbor, and I want you to read through this case study. Read through this case study, and then you don't have to post this on Facebook, what they say, in case they get it wrong. But what would you do in this setting? Now, I recognize for some of you this isn't the patient population you deal with, but just pretend. What do you do at the end of this? Okay, so some of you have already said you tell the kid what you're going to do. Any of you not tell the kid but do it anyway? No? Why not? Well, how do you know what's ethical? Who tells you what's ethical? What could you do? Yeah, so you may decide, I do want to do the urine test, and I do want to do it for this, but I'm going to bring the kid in, either by telling the kid, someone said that, or by trying to convince the mom that maybe this isn't the best choice for their long or short-term relationship, right? Okay, so you've just thrown out some things that I don't know what the right answer is. We'll kind of come back to it because some of the things, but the point is in that very deeply scientific philosophical phrase, there's more than one way to skin a cat. And the reality is that there usually isn't just one ethical path to take. Sometimes there's a variety of different ways to get at an ethical result. And so I want to talk a little bit about how you as practitioners can walk through the steps to find a way to get to an ethical result, and think that through creatively. And some of you obviously know that. Now, most of us, when we talk about ethics, and some of you brought those up right away, we think about the big things, the beginning of life, the end of life, medical technology and how it can do all sorts of things, but comes with all sorts of associated risks, human enhancements. And so oftentimes when we think about ethics, those are the big things that we think about. But for most of us, we face smaller things. Most of us are not charged every day. Now, I obviously work with a number of doctors who every day are facing, life and death, and maybe that's some of you, but for the most part, it probably isn't. It's probably smaller stuff. So they recently have done studies among pediatricians and pediatric residents about, what are the ethical dilemmas in everyday practice that docs and medical providers like you face. And there's kind of a clustering of answers. The first one is just promoting the child's best interest in a complex, resource-poor home or social setting. And you know this. We get these kind of things all the time. One, you always have to gauge, you have to kind of do the wallet biopsy. Does this person have insurance? And what kind of insurance do they have? Because that may impact what kind of things I can recommend. And particularly back in the day when HMOs were much more, spread throughout the United States, there were times where somebody with an associate's degree would be on the line saying you can't do that, and you would be saying, hey, hold on, I want to be able to do this. And so how do you provide that? Or you have a situation where there's just something going on at home that's terrible, and the parent is the antagonist in the situation, and you're trying to figure out, how do I provide the best care when I have a situation where I really have to do some kind of work with the parent. Or it could be economics, it could be trouble at school, all sorts of social or mental things that you're not a trained counselor, but you really realize you have to do a lot of damage control outside of. So that's one of the things that pediatricians and pediatric residents talk about. Another one is managing the therapeutic alliance between patients, parents, and caregivers. Sometimes it's because you may have parents who are divorced, who want two different things for their kids, and they're using the kid as a ploy in their larger marital spat. And the decision they're asking you to make isn't about the kid's welfare at all. One of those decisions may be, but the point is they've got the kid as a pawn in whatever larger game they're playing, and you have to figure out, or it may be that the parent is asking you to do something that's unethical, and how do you bring the parent alongside to make wise decisions? How do you, make them allies in the situation? Another one is protecting privacy and confidentiality, particularly for those of you who deal with adolescents. You sometimes learn things that the parents don't know, or the parents want to learn things that they don't know, and they want to use you as a proxy to get that information. And how do you navigate that? And that can be, one of the really tricky things. And then there's the appropriate use of professional authority with colleagues and with clients. Now, this is important for two reasons. One is you can understand this with parents. Sometimes you'll get a parent who wants a letter of recommendation to a school, or just kind of a character reference if they're about to lose their home, but they could get somebody to vouch for them that they're good character, and you need to write that. And there's some people for whom you can do that, and being a doctor, being a medical professional carries some weight. On the other hand, sometimes the parents who you deal with really don't have very good character, and then do you want to use your professional leverage for those types of things? The other situation obviously is with colleagues. Some of you work with people who are incompetent. You would not send your kids to those people. Now, none of you in this room, but they didn't show up today, obviously. So that's or you're a mid-level provider, and the people for whom you work don't know as much as you do about a situation, or whatever. And there's conflict. I did a historical analysis of the baby doe laws. And those came out of initially a conflict between two doctors, an obstetrician and a pediatrician, about what was the best choice of action, because one doctor was saying the baby had esophageal atresia, and the obstetrician was saying the baby's not going to make it, and the pediatrician was saying the baby will do okay and it'll be tough, but you can do this. And the parents didn't know who they should believe. So what do you do when you have a situation where you have two doctors who are giving two different sets of advice and the parents don't know what to do? And that can be very difficult, particularly if there's only two of you in the same practice. So these are some of the issues, the ethical issues. And then there's a number of other things that drive, the challenges that you face as physicians in terms of making ethical decisions. Some of them are health disparity issues, race, ethnic, gender, that they cause you some deep concern about how do I address this situation? How do I fix a problem that really has roots that are outside of a medical problem but are maybe economic or social or what have you? Physician bad behavior, you know this, where oftentimes you may work in communities that have deep mistrust of doctors and hospitals, and you have to gain that trust. But there's been a long history of doctors behaving badly that live in the back of the mind of people about what are you doing? Are you treating me as a guinea pig with this? Or are you really giving me the best advice? And they have a long legacy of either personal or kind of community memory of how doctors have behaved badly for a variety of reasons. Cost containment is another one. Sometimes there's situations where something is real expensive, either for the patient or for your practice. And do you give the best care when it comes out of your wallet? And a lot of this has to do, obviously, with coding and appointments and whatever, and how do you record those things. There's going to be times. So I work in association with Parkland, and we have a lot of obstetric processes that are bundled together. And so sometimes we'll give all sorts of prenatal care to a woman who then goes and delivers someone out somewhere else. And so Parkland doesn't see that money. And it's just one of the things that just, and then of course, then they come back for follow-up afterwards. And it's just a very difficult thing. But you all have the same kind of thing, and it's a challenge. And you don't want to commit fraud. On the other hand, you want to figure out a way to make sure that if you're doing extra things, how do you code for this visit? What was it? What is it? And those can be real challenges. And so there's lots of questions that you face, and I'm going to solve them all in the next 15 to 20 minutes. Now, the truth is that most of you struggle with that. Probably doesn't necessarily keep you up at night, although it might. But in the survey that I was telling you about, most pediatricians, most pediatric residents believe that their ethical education, to the extent they got some anywhere along in their medical training, that it really didn't prepare them for these common dilemmas. Now, you know that for a variety of reasons, because you probably also didn't learn how to run your own practice. You didn't learn how to deal with insurance companies. Right now, one of the things I do is I teach health policy to the fourth-year students, and I show them actual health policy forms or health insurance policy forms that they're going to be getting and filling out, and we walk through what these things are because they've never seen those before, and dear God, they're going to see them, and they're going to have to hire somebody who's going to be fighting with an insurance company. And how do you hire staff who can be really, really nice to the patients when they come in the room, and a bulldog on the phone with the insurer who's saying, I think I'm not going to, and that's tough. And so a lot of people say that their training didn't provide them with that. In fact, the study said that 45% of graduates of pediatric residency programs said that their ethics education was fair or poor. And most pediatricians don't feel a real strong confidence that they are able to make these decisions. Now, Dr. Spock, back in the day when he talked to parents, he said, the best person who knows the most about your baby is you. And so I actually want to say to you that if you feel insecure about these things, I really think that you do know how to solve these problems. It just, sometimes you need help in figuring out a way to do that you can live with yourself and defend it to others. And so when I teach medical ethics, I don't have like an answer sheet at the back that tells everybody, here's the right answer, you failed or you didn't fail. What I try and do is walk them through a process whereby you can, at the end of the day, feel like the decision I made is one that I can live with and one that I can defend to other people based on a set of ethical standards that I believe in. So before we do that, we need obviously to talk about what ethical standards are out there. I'm going to not go into like too, jargony talk, but there's a variety of different frameworks, and I've kind of got them listed here. And I've broken them down. I hope it's okay, but I've removed most of the big phraseology. You'll see some of them in parentheses there, but there's a couple of ways people do it. One is through what they call universal answers. And so I talk about ethics for everybody. And there's two ways of going about doing this. The first is what we call intrinsic ethics. These are like the laws of the universe. These are the laws of nature. These things are right. They're absolute truths, and they exist regardless of whether or not we exist. And whether or not we follow them, they are there. So those are deontological. That's ethics for everyone. Everybody's supposed to follow these. And there's lots of philosophers. The key philosopher who people think of when they think of this type of ethics is a guy named Immanuel Kant. The idea that if you want to test whether or not you should do something, take that rule that you're trying to follow, elevate it, and make it a universal rule in your mind. And if everybody else ought to follow that, then go ahead and do it, because it's a universal law. That breaks down for a variety of reasons. We don't need to go into that. The other way of thinking about universal answers is what they call extrinsic. This is consequentialism, but you can understand this by the most good for the most amount of people. That you look for the biggest benefit, the greatest benefit to all. And that if you can say this decision would benefit the most people, then that's the right thing to do. So we talk about that as ethics for everyone, that everyone gets included by this benefit, this choice. This benefits the most people. The problem, obviously, if you're a doctor, is that that ethical rule sometimes doesn't necessarily mean that you're going to make the greatest decision for the person sitting right in front of you, because the ethic that benefits most people might harm the person in front of you. And that becomes a challenge, because particularly for you as medical providers, you're concerned about that individual patient right in front of you. You're not thinking about how that will impact everyone around you. If you have read the health policy study by Atul Gawande on healthcare financing in McAllen, Texas, he talks about how McAllen, Texas kind of had this medical model where everybody was competing to provide the best care for their patients, and in the process, they just started to accumulate all sorts of services that weren't really necessary, were very, very expensive, so that McAllen became one of the highest cost places to get care in the United States. And El Paso, which is not that far away from McAllen, has basically the same patient population, and its costs to Medicare were half. And so Atul Gawande goes down to McAllen and he tries to figure out why. And he said that there weren't like a group of doctors sitting in a back room smoking cigars and saying, "Ha, let's rip everybody off." It was individual doctors trying to do what was best for their patient, but also not wanting to lose their patient to other people and expand the base, making individual decisions for that patient. They weren't thinking about the larger health costs involved. And sometimes that can be a real trick. Well, on the flip side, there's what we call radical answers. Maybe most of you aren't this, but you may know some people who are. And these are really very social justice-oriented folks. They're looking at the ethical dilemma is, it may be based on gender or class or a race or an ethnic group, providing justice to the people who are downtrodden. And oftentimes these are folks who'll go into kind of overseas work or hook up with the Peace Corps or WHO, but maybe, well, some of you. And that is, you see your job is to make sure that poor people don't get screwed. Poor people get the access they need. And that's one way of looking at it. And then there are what we call community answers, ethics for the community. And this is people who are willing to say, I'm not going to make a claim about what everybody ought to do, but this is what I, as a Christian or a Jew or a Dallas Cowboys fan, or this is what we do. Now you can understand this. When I played, I'm Canadian, so we don't play intelligent sports. I played rugby, which is a combination of football and soccer. You don't wear any equipment like in soccer, but you bang your head against other people just like in football. So when I played that, I played for a coach, and he would have us chant at the very start, "Who are we? We are Warriors." That was our team name. RFC, Rugby Football Club. We don't kick, we don't fight, we just play this game right. Good. And his point was, is when you get out there, he wanted us to play hard, but he wanted us to play within the rules. And it didn't matter if the other team was cheating. He said, that's not who we are. And you know that too, because your parents probably pulled that line on you. I don't care what Billy's doing. Billy's not in this family. And that's what community ethics are. I don't care what they do in another practice or another hospital or another religious tradition or whatever. This is how doctors in this tradition practice. This is how Christians practice. This is how, humanists practice. This is the value set that we have, that we follow, because this is who we are and this is part of our tradition. I'm going to use that as a springboard because I think that's something that we can gather around. Not the Dallas Cowboys, we're all Dallas Cowboys fans because, of course, only half of you are. The other half were, but then, we fired Landry. But Western medicine has a long tradition of values that it sees kind of at its core. This isn't the only way to think about medical ethics, but it's a useful way for you to hang your hat and say, this is how to think about medicine. You've seen these terms before: beneficence and non-maleficence, autonomy, justice. These come all the way from the Hippocratic Oath down through Western tradition. These are the values that you probably got trained in. So beneficence is the idea of acting for the benefit of others, doing good to your patient, prevent or remove, that should be the word prevent or remove harms. That's your job, is to prevent harms or to remove harms, improve the situation. Non-maleficence, this is kind of the huge Hippocratic term, but do no harm. In fact, that's how the Hippocratic Oath starts, right? First, do no harm. The point is now look, we do a lot of things as doctors that would be crimes if other people did them. Yeah, I mean, you know that, right? In most situations, if you stick a knife in someone's belly, that's called stabbing. Once we realized we had too many kids, I went for a very specific surgery that made sure we weren't going to have kids anymore. And when the doctor was doing that, I realized in any other given situation, this would be a very awkward moment. But I actually signed up and am paying money for this particular procedure. And the point is that you have a social contract with society that says that we allow you to do things that in another context would be entirely inappropriate because you are following this mandate, that the good is outweighing the bad, that you are doing something and we reward you accordingly because you are carrying a burden, not to do harm, but to do good. And this is a principle that I think a lot of doctors, and one of you mentioned it even when we talked about medical ethics, what comes to mind, and it's, helping your patients, caring for your patients. This is the thing that probably most of you, when you wrote your essay about why you went to medical school, it hadn't gotten beaten out of you at that stage. I guess most of you are pediatricians, so the fact is it still hasn't probably gotten beaten out of you. But the point is that this is why people go into medicine, because they want to do good. People go into research because they want to become famous, but people go into medicine, pediatric practice, because they want to care for other people. So these are kind of one of the main principles. The other one, the other one is autonomy, respect for people. And this is a challenging one, particularly for you all, because you're dealing with people right on the cusp of being able to make their own decisions. But you as doctors value this, that when a patient is able to make their own decision, you let them make their own decision, even if it's a bad decision. You do your best to convince them otherwise, but you recognize that to treat people with dignity and respect means you allow them to make their mistakes. You are not judgmental about those things, although you will advise them, do this again and that heart attack will come on. Of course, maybe not for your population, although some of them are starting to get that way, aren't they? But this is the basis. Some of you mentioned medical ethics, you said informed consent. But this is where you tell the patient what's going to happen to them and you get them to sign on. Now in pediatrics, oftentimes for you it's more assent of the child and consent of the parents, but that changes kind of along a scale. But this is one of the key values. It varies obviously with the maturity for the adolescent, and obviously you know as well as I do, particularly if you have kids, but even if you've just hung around with adolescents at all, that you can have someone who's the exact same age as somebody else, but their maturity level is very, very different. So this is one that really requires you getting to know your patients, knowing what they can handle, what they can assent to or not. And it obviously includes a relationship that you have to build with the parents about knowing how well they are informed. And this is why when we talked about informed consent, it's really a process. It's not an event. sitting down and having people walk through what are the implications of this particular procedure, this particular course of action, that type of thing. The last one, which I won't go into great detail on, but is justice, the fair adjudication between competing claims. This one is kind of the larger kind of social context within which we work, but respecting people's rights, morally acceptable laws, fair distribution of just resources. But I need to let you know that throughout American history, doctors, medical providers have been at the forefront of asking very deep and important structural questions. The entire idea of how we structure cities was because medical providers would go into some of these apartments and say they're so crammed together that people are getting sick. So we need to think about open living spaces. Those were doctors and nurses and medical providers who were the ones who were at the core of that. Obviously, public health in general, clean water, clean milk, all of those things were things that doctors said, this is something that, from a public health rationale, is something we need to stand up and say we need to do something about this. And that's not always a role that doctors feel comfortable about. On the other hand, you know very well that sometimes you do this on a little level with the different patients who you see on an individual time and place. And then there's the question of paternalism. Because you have these medical values, but sometimes you have to fudge on one to do another. And the question is how do you do that? Paternalism is the idea of saying, when is it okay for me to interfere with the liberty of someone else for their own good? And this is where you have to strongly advise a parent to do this. You have to not always tell them what's going to happen because you don't want to scare them. And these are really tough decisions. This is where you as a physician, you as a provider, walk through making decisions. And when do you assert your authority? Now, some of you, it's easy. You have a set of patients who are very compliant. They just come and they sit and they do what you want. There are others who come and they bring in everything off of Wikipedia and WebMD and whatever, and they basically tell you what you're going to do. And they got their MD for the last half hour while they were scouring the internet, and now they're going to tell you. And some of you, I had when I was getting my PhD, my advisor was an MD PhD, wonderful man named Peter English, and he was a pediatrician who was practicing. And he said, sometimes it's very difficult because I have patients who are wonderful, but they're either illiterate or they have no health literacy, and it's very difficult because they take me very literally. So, for example, this family came in, and the family in general was, but the boy was particularly struggling with obesity. But he would always have a big, 72-ounce Coke. And so Peter, my advisor, who was their doctor, said, he's really struggling with his weight. He needs to watch what he eats. He needs to start exercising. For example, every time I see you, he's got this big cup of Coke. I don't want you to have him drinking Coke anymore. Mom said, okay. A month later, 6 months later, they show up. The boy's carrying a 72-ounce cup. He said, I thought you agreed with me that we would have him not drink Coke anymore. And she said, it's not Coke, it's Pepsi. And that's where he realized, okay, this is where I'm going to have to take them by the hand and actually tell them what they can and cannot drink. These are patients who will do that, but they take me very, very literally. And so I have to think through all these things for them. So paternalism, it's very, very difficult, but there's kind of a sliding scale. The balance between autonomy and beneficence differs between patients, and it evolves over their life course. So sometimes when they're younger, you're focusing more on what's their good, and as they age, you start to think, let's allow them to make some decisions. We want to strongly encourage them to do what's best for them, but we recognize that as they get more mature, somewhere along the line, it's their life. And we have to think that through and make sure that we help that development along. And it oftentimes differs between families, sometimes whether it's cultural or intelligence or health literacy or whatever else, that for some families you need to make a more proactive choice, and other ones you need to step back and have them make the decision. One of you mentioned too that sometimes coming alongside them as their ally and helping them, you know as well as I do that sometimes if patients think that they made the decision themselves, that it goes a long way further in terms of them acting out, healthy behaviors rather than if you tell them to do something. If they can come to the conclusion with guided solutions from you, that can be one of the best ways to make a long-term impact. So, when I talk to my medical students, I have them walk through these 5 steps, and we can talk a little bit about them afterwards if you want to. Let me just check on how I'm doing on time here. Okay. The first one is clarify, and this is if you're in a situation at work, in your clinic, or what have you, or maybe you're reflecting on it afterwards, determine the nature of the problem. We talk to students about thinking through what was at issue, because sometimes what immediately seems to be the problem isn't. My pediatrician has helped me many times, because I will call or show up for an appointment and I will say, he's got this fever and I need to get it under control, or he's doing X, Y, Z and I want to, and he'll say, now, help me understand, is this that you're really concerned about him, or is this to give you peace of mind? And it helps me clarify, but I think too, sometimes you as pediatricians have to walk through the ethical dilemma and say, what's the real issue here? Because sometimes something that seems like the problem isn't really the problem. There are things behind it. In the very first case study we talked about, the real concern was that the mom and the son had a broken relationship, that the mom didn't trust the kid. So she wanted to use you as the doctor to find out about the kid without confronting the kid. So you could view it as, I think the APA has rules against me doing that. But as a physician, maybe this is where you come alongside and say, let's talk about those things. Let's talk about how you and your son can establish a trust relationship. Now, of course, I recognize this is easy for me to say because I'm not in the room where you only have 7 minutes to churn out a time and then. But sometimes that's where afterwards, where you need to sit back and stop and say, what was the real issue there? And then maybe in the future, when I'm faced with a situation like this, I can come up with it. Now, there's ways to do that. List a full range of options. So I work at the Children's Hospital, and we have oncologists and neuro-oncologists. If either of you, there may be some in the room, or you may know some of the darkest humor I have ever heard are people who live with, death all the time. And so but they can come up with a whole long list of ethical, options and solutions. But usually none of those are ones I'm going to do. But this is where you need to, what are some things I could do? What are some things I could do here? And then, of course, you want to eliminate the impractical. So calling CPS and adopting the kid and having him come live with me, that is a solution. It's a bad solution, but it is a solution. Illegal, I don't need to go through a list of things like, capture the parent and hold them kidnapped while you raise the child. Those are bad things. Improper. Now, sometimes there's inappropriate professional boundary ones, and obviously you shouldn't do those. But sometimes there's improper ones that are just culturally inappropriate. And I don't mean that you're necessarily violating any rules, but it might not be a good solution for this family. If you're talking to a family that is, very staunchly Catholic, and as opposed to, contraception, saying condoms are the answer is probably not the best way to go. Not because condoms aren't an answer, but because perhaps for them, thinking through, natural childbearing and ways to have natural prophylaxis may be a way you could advise them. I'm giving that as just off the top of my head, but there's points where cultural appropriateness, where you need to say, I work within the culture, the context. We had a situation at Parkland Hospital. We're a trauma center there, and so we have lots of kids who come in who are injured because of car accidents. And so we tried all of these programs. There were largely, disproportionately, was Hispanic families that didn't have car seats and the kids would get injured. And we were trying, how do we do some type of intervention that will get these families to do this? And we even kind of would be able to localize it to where these individuals lived in Dallas. We were putting up billboards and having promotions where they could get free seats and all this kind of stuff to get. And finally, we hired an anthropologist. And the anthropologist said, just hold your next event at the Catholic Church and have the priest bless the car seats. And that's what we did. And the number of car seats in that population we saw went from about 25% to 70%. because we realized that the way we were trying to get the patients to do what we wanted them to do was improper. It was inappropriate culturally for them. And when we found a way to solve the problem, but do it within their context, within which they said, okay, this is then blessed by our priest, this is something we're going to do. And we saw the numbers of kids coming to the hospital from that community go down. And the point is sometimes we come up with solutions that they're not proper for the context. And we think we've come up with a great solution, and it turns out it's not, because we've ignored a whole host of cultural values that may not be the right ones for the family. And so they are not happy with your solution, even though you can live with yourself at night. And so that, of course, you only have 7 minutes or 14 minutes with a patient. That takes a relationship. That takes listening. And I should say, I'm going to say this throughout in a couple ways, but this is where talking sometimes to your nurses and mid-level providers about the families can be extraordinarily valuable, because they gain insights into the people that you might not. Because you walk in with a white coat and everybody becomes a patient and they assume the patient role. You walk out, but the nurse may still be there doing whatever, and oftentimes families kind of let their guard down and they talk. And then you learn some things. Anyway, that's a long way of saying develop justifiable options. And by justifiable options, we usually mean things like, is this a decision that if I told my wife or my husband, my colleagues, my children, that I wouldn't be ashamed to say it out loud? It doesn't have to be the one you do, but it does mean that the solutions you come up with are ones that you could justify. And then the next thing you do is you evaluate them. Now, obviously, this isn't going to happen in 7 seconds while you're running through this process, but we encourage students to, create kind of maybe a community of ethical reflection, a case group. This could be something you do once a month in your practice. At your hospital, maybe, you could call me up and take me out to lunch, and then we could talk through some of these things. But where you sit down and you reflect on what's the best thing to do, and then you find out which options sacrifice which ethical principles. Because oftentimes, it isn't that you have a decision between right and wrong. It's often between good and better, or better and best, or worse and less worse. And those are the ones that are really the struggle. And that's where you have to say, which are the ethical principles that I'm willing to fudge on? And why? And distinguish facts and assumptions. Sometimes you're making assumptions about people and what they value, and you have to say, do I actually know that, or do I just think that? Because sometimes, because of their cultural background or your cultural background, or because you don't know enough about the situation, you're making assumptions that may not be true. The other one, consider credibility of the sources. At Children's Hospital, we oftentimes will have an in-law pull one of the doctors and the nurses aside and say, don't listen to the mom, she's crazy. This is what the kid wants to do. And the problem is now what do we do? Because we have a mom or a grandma who's saying one thing and a ma who's saying something else. And that can be very, very difficult. And particularly if you're a doctor, you don't have enough time. And this is, again, where oftentimes in our ethics committees, we will do a poll of the nurses and the mid-level providers, because they oftentimes know what's really going on once the white coat leaves the room. It's to ask, what did you see? And sometimes the people we ask are our clerks and our registrars who are bringing them in while they're sitting in the waiting room, because you see the family dynamic that's going on there. And you see, the dad's browbeating everybody. And then when you get into the room, he says, here's what we're going to do. And the clerk says, I just watched them out there, and the kids do not want to do this. And that doesn't mean that you overrule the dad, but it does mean that you make sure you know who your sources are. And that's tough, and I'm obviously talking, but some of you are in small towns where you have long-term relationships, and you know these things. And this is where it's really people management. Also, ask for help from advisors. Now, I'm at a hospital system, so we have ethics committee, formal ethics people. You may not have that. Sometimes, you can, SMU has this new program with legal mediators where you can ask somebody to give you advice. It's not actually bringing a lawyer in, but it's somebody who knows kind of ways to mediate conflict so you can find a solution that's amenable to people. Obviously, if you have religious community, religious leaders can play an important role, or just really wise people. You can do it even amongst yourselves, where you create kind of a journal club where you say, can we get all the doctors together and just give me your best idea here, because I don't know. We have a whole bunch of surgeons who they're trying new things in surgery. But when you're a surgeon, sometimes you don't have time to call an ethical consult and wait a week and a half and that kind of thing. And so we have ethical innovation meetings. And it's where really quickly we get people together, and the person who's about to do something, try something new, or did something new and says, is this something we want to do going forward? You try and get some kind of reflection that the group has that says, yeah, that's who we are, we're okay with that or not. And that way you develop a consensus within your community, your practice, your small town or wherever, where this is who we are, this is what we're about, getting help from people. And then, of course, you decide. You apply these 3 questions. Are you treating others the way you'd want to be treated? Will you decide this way if it was in the newspaper? And would you want your child or loved one to observe your rationale and your actions? Would you want to... My sister recently was diagnosed with brain cancer, which is terrible. But the key question I asked my doctor is, okay, we're having these people do the surgery. I'm sorry, it wasn't my doctor, but a doctor who my family knew who worked at the hospital. And I was trying to think, do we just up and take my sister and ship her down to UCLA to get she lives in California, and or do we just have the doctors at this particular hospital do the surgery? And the thing I asked my doctor is, do you want this, if this was your wife who had this problem, would you want this doctor doing this for you? And that's a question you need to ask yourself. In this situation, if some doctor were looking across the table at me say, this is the thing you need to do for your kid, for your wife, for your whatever, would you be able to live with that? And the doctor was able to say yes, and I think we feel really good about it. But that's one of the ways, when you're trying to decide to do something, if everybody knew what I did, would I be able to live with that? That doesn't mean it was easy, but it does mean that you're putting your money where your mouth is. And then implement it. Develop your plan. But we always tell people, record it somewhere, oftentimes just in the patient's notes. Tell what you did and why. One, because there's going to be some lawyer somewhere who's going to come back and ask, and if it's there, then you said, I told the patient to do this and they did something else. Record it somewhere. Oftentimes get somebody else as kind of a witness to your actions and your decisions. We usually tell doctors at least to have another nurse, but maybe a doctor, but somebody else who can vouch for what you're telling your patient to do in an ethical quandary. So there's somebody else besides you, so it doesn't become a he said, she said, or whatever else. That doesn't mean your patient is always going to get it, but try and get some observer, or at least take notes of what you told, so that later on you can reflect on those things. This is where, and I'll just mention this again real quick, where you can rely on services that are available. If you're at a hospital, you may have an ethical consult that you can call in. Could be an ethics committee, social worker. You may need a legal or judicial intervention, and that sometimes happens. My hunch is it isn't always, but obviously if you've got a kid who's diagnosed with cancer and you're recommending that they have chemotherapy and radiation, and the mom looks at you and says, I think we're going to go with the guy who uses apple spice, then that's where you call in a mediator or a legal team and you say, no, we can't have this. You don't call up the apple spice doctor and let's do a consult together. There are times where you don't show that kind of professional, all right, let's see if we can find a good solution. That's where sometimes you just have to intervene, because there are some patients who just have no concept. I did a history of kids with HIV. And there were situations where kids with HIV were adopted or put into foster homes of parents who did not believe that AZT and the highly active retroviral therapy worked, that they believed it was poison, that HIV wasn't real. And so they took the kids off meds. And so in a situation like that, they would say, well, we have a doctor who tells us that these drugs are bad. In that situation, you as the provider don't say, well, let's get that doctor in here and we'll talk about it. In that situation, that's where you call in the legal team or a mediator and you say, we need to take immediate steps because this child is in some type of danger. I don't imagine most of you have those situations, but we have had those kind where we are. And there is nothing wrong with that. Some of you may have had to call Child Protective Services, and that is not an enjoyable thing, but I promise you, you will live with yourself if you make a mistake on the strict end, rather than very well if you didn't call Child Protective Services and you find out later that the kid is hurt or the kid died. And some of you know what that's like. And then, of course, you monitor it. I would say, again, I want to encourage you, get a community of people where you can tell them what you're thinking, what you're doing. Develop a culture. It could be your faith community. It could be, at your church, there's just other doctors and you meet once a month and you talk about the hardest questions that you had, the hardest things you had to deal with. It could be within your practice that you just once a month talk through, here was the toughest decision I had to make and I tried to get it right. What do you all think? So that you have a culture where you're communicating with other people so you don't have to carry these burdens on your own. And you're willing to say, we messed up. There's lots of studies that show when doctors say sorry that they can avoid getting in legal problems. If they just say, we did our best and we made a mistake and we're really sorry about it. You obviously need to talk to your legal people before you rush out and do all that. But the point is that sometimes doctors are really afraid to say sorry, even to their colleagues, because there's this idea, particularly from med school. So my wife's a doc, and I remember during med school, she'd come back and always tell me exactly where she was in the class in terms of her hierarchy. And, I'm a historian, so it's all fuzzy and not really real anyway. So, we didn't have quite the same thing, because I could just bluff on something else and get away with it. But, for you, that hierarchy is real, and it carries out, into med school training because you're getting pimped by some attending who really wants to make you look like a fool. So you're ordering every test under the book. And then all of a sudden to get out and say, yeah, this wasn't the best decision, that's hard for docs to do. And so I would encourage you to try and find a safe community where you can talk through these things and have some type of ethical QI, basically, so that you can develop a culture where you can correct and improve. The last thing is to say that all behavior forms habits. The reality is that if you want to be an ethical doctor, the only way to be an ethical doctor is to be an ethical doctor. And to do it over and over again. And that's what virtue is. It's taking actions and making them habits. It's when you make 1,000 small decisions to act ethically. Some of them are difficult, but you get used to doing it. When I think of medical ethics, I think of my friend Mike Kolmansberger. Now, you don't know Mike, maybe some of you do, but it doesn't really matter. What matters is that on January 15th, 2009, he was in New York City. I had been there about a week earlier, and he was on Facebook complaining because he was on his way to the airport, and it was so cold and the snow was coming down that the window in his taxi had frozen open. So snow is coming in. He's on Facebook saying, I hate this is terrible, and I'm laughing, making fun of him and that kind of thing. And I didn't think anything of it until later on in the day, I'd heard that an airplane had gone down in the Hudson River. And I thought, well, I'm going to go on Facebook and make fun of Mike, tell him, aren't you glad, your window was down, but aren't you glad you weren't on that airplane? So I go on Facebook to make fun of him, and his wife has posted saying, Mike's alive. And I realized Mike Kolmansberger, my friend, was on flight 1459 for U.S. Airways out of LaGuardia. That pilot, Solensberger, was able to take, they flew through a flock of geese. Both engines go out. And they have between 2 to 3 minutes over New York City to figure out where to land. And he safely navigates this plane full of people over a metropolitan area with millions of people, hundreds or thousands of whom could have been hurt if this thing crashes, and he lands it in the Hudson River, and everybody makes it out alive. Now, what's about medical ethics? Well, see, the thing is that Sully didn't say, oh crap, we just hit a bunch of birds. Where's the pilot manual? Because I think in chapter 8, they talk about what happens when the engines go out. No, before anybody ever knew who he was practicing what to do when your engines go out. He practiced when nobody cared and nobody watched. What do you do when your engines go out? Where do you land when your engines go out and you're over a city? How do you protect the people? And he got so good at practicing those things that he started to teach it to other people. He wrote the textbook on what to do. So that one day, in real life, when they drove through a flock of Canadian geese and both engines went out, people talk about how miraculous it was, how providential it was. It may well be providential, but it wasn't miraculous. It was the lifelong set of small decisions that one pilot had made to know what to do in a crisis, so that when that crisis hit, he had the habit of responding. And so, without having to think, he did what needed to be done. And the point is most of you in your daily lives don't face medical ethical decisions about end of life or the big medical ethics things. But you face the small ones. You don't have to use my 5 steps, but I want to encourage you to use some type of reflection on how to be a more ethical doctor and make more ethical decisions. Because as you do that, they will be habits. And so you will face your crisis as a medical provider. And in that moment, you're not going to be able to go back to my slides and know what to do. There'll be a time where you have 7 minutes to make a decision about something. And hopefully in that moment, you'll make the ethical choice. And I promise you that if you make this a practice, you make it a habit, you take the free throw shots when no one's looking so that in the crisis of the game you can sink it. Your patients will thank you. Their parents will thank you. My kids will thank you. And I will thank you. And you will become the kind of doctor, when you wrote your letter saying, I want to become a doctor, you will have fulfilled that vision. So I encourage you to become ethical doctors every day by reflecting on who you are and what you want to be and how to go about doing it. Thank you.